Good afternoon and welcome to this online discussion of COVID-19 hosted by the Irish Scientific Advisory Group, ISAG. Amazingly, we're going into this summer with COVID case numbers across these islands considerably higher than they were this time last year. It's certainly a clear indication that, unlike many other countries, including some European countries, we have not successfully controlled the virus and that we need to be thinking differently about how we are proceeding. Of course, the big difference this year is that vaccination has become an important tool in bringing the virus under control. It helps us avoid serious illness and death. The deployment of vaccines, happily, has so far been a major success, but there's still some distance to go in what remains a very difficult situation. The lobbying of interest groups to remove restrictions prematurely has been a powerful feature of the current situation, with the current Delta variant having become dominant and bringing with it greater ease of transmission, reports of more serious illness, and an increased ability to reinfect those already fully vaccinated. The potential seriousness of our situation demands careful consideration and decision-making, and a clear understanding that COVID-19 is going to require robust public health measures for some time. In particular, the evidence base around long COVID has made it very plain that avoiding deaths, which is extremely important, is not the full picture. It would be immoral and reckless to allow people to become infected with a serious infectious disease that could cause disability, and disability that could last for some considerable time, if not permanently. So it's time to have now our routine data presentation about the situation across the island. And can I hand over now to Dr. James Merrick, who is a mathematical modeler with a distinguished pedigree, having been a graduate of UCD, MIT, and Stanford. And he will talk to us about the COVID-19 situation. James, over to you.
Thank you very much, Gabriel, for the kind introduction. And so, do you agree with Cardia? I guess hope everyone's doing well today. If we could bring up the slides, please, Ben. When the slides are coming up, we can just mention the general trend is a continuation of the trends of 2 weeks ago. I suppose they've, in terms of cases, things have been going the wrong direction. That's the summary, and we'll get into some of the details now. And of course, as every week, there's a team, whole ISAG data team effort behind this. So want to thank everyone who makes this possible. So we'll start with Northern Ireland, as we've started with in up to coming weeks. So it's 2 weeks since our last webinar. And actually, the last time we showed this chart, the limit of the y-axis was at 20. So we had to increase the scale of the y-axis just how things have changed in 2 weeks. So this is the daily average cases per 100,000 in Northern Ireland by age group. And the yellow line is the one shooting up there. It's the 20 to 39 age group, the top line. The black line is the population average. So we see this sharp continuing increase. And one thing that really struck me when we put the charts together last night was the lines at the bottom also increasing. That's over 60s essentially. And so when we looked at the increase 2 weeks ago, the increase in cases were in the younger age groups, but the older age groups were staying relatively stable. But that has changed. And so that's just the idea where, no vaccine is 100%. So if there's enough of the virus circulating in the community, it will start getting through to these age groups also. So so that's the situation in Northern Ireland. Sharp increase, particularly among young people. And then just to give the UK as a whole, perfect. So England, first of all, maybe just a very sharp, ongoing increase in England. There's been, for people tuned in, there's been lots of discussion about the strategy there in recent weeks. Scotland has actually was increasing at an even sharper rate when we last looked 2 weeks ago. That has come down a little bit, but it's too early to say whether Scotland has turned the curve. There's a possibility that there was a bump maybe in June, maybe the Euros, maybe other things going on, and we're kind of returning to an underlying increasing trend now. It's too early to say there, but whether Scotland has turned the corner or not. So I think as per the introduction by Dr. Scally, we see the situation in Britain. Our neighbour here in Ireland is there's a lot of the virus circulating. If we could go to the next slide, please, Ben. So this is in Ireland and Republic, and I like to show this chart because it relates to sort of the number of people hear in the news every day. But this is the daily average, 7-day rolling average in the Republic. And, going back to early May there, we were at this period where we were oscillating between 400 and 450. Then when secondary schools closed, we went down to 300. But then we started to see an uptick in our presentation 2 weeks ago. And this has continued since. So you can see this upward move to the right on the right-hand side of the chart, up, breaking through well over the 500 mark now. But this is consistent with what we talked about and what was seen in England, where during that decrease in cases, the non-Delta variants were decreasing, but Delta was creeping up underneath. And as that's become predominant, the increase has continued. And so obviously, we're probably all benefiting from things being more open and outdoor activities, but transmission is still happening. And with Delta, clearly activities that there was no transmission happening before, there's now transmission happening. So it's clearly just a concern to us all over the next few weeks and months. And just I would say at this point, I suppose through these charts, I'm focusing on cases, while the link between cases, hospitalizations, and deaths has changed. Clearly, it's not broken, as we'll be discussing today. If we go to the next slide, please, Ben. And just to show the breakdown of those cases by age group in the Republic. So the green line here on top is the 19 to 24-year-old group, and that was when we last talked 2 weeks ago. They were away from the pack, we'll say, and that's increased. And so the increase is in that group, and then this blue line is 13 to 18, and that has gone this upward trend too. Unlike in Northern Ireland, it hasn't passed into the older populations yet, but that's probably what's ahead of us if we kind of follow Britain in terms of that rate of increase. Obviously, things are different here with indoor dining, indoor hospitality, and the plans for reopening that are going to be different. So we'll see how that plays out. Next slide, please, Ben. Yeah, just on the vaccination. Since we last talked, particularly the fully vaccinated number has gone up. So we were at 2 weeks ago, we were at 41%, and now it's gone up over 56%. So the vaccinating program is continuing apace, but as we've discussed many times on the webinar here, it takes time until that immunity builds up. So next slide, please, Ben. Just wanted to give a little bit on the world situation. I showed this chart a few weeks ago, and we were on. This is the world confirmed cases, globally confirmed cases since the start of the pandemic, and there obviously there's a lot of caveats, different regions, different reporting requirements, but it kind of gives an overview of where we are. But we were on the steep downward curve a few weeks ago, but that's shifted, and Delta is a big part of that story of global cases confirmed cases starting to increase again. If we go to the next slide, please, Ben. And then just the European context, just pull a few stories out. So this is confirmed cases per million people in Europe, so kind of weighted by population. Ireland is a little bit above the European Union average, but there's quite different stories across the EU. If people didn't see it, the Netherlands case is worth pointing out. They basically opened everything without many restrictions a few weeks ago, and Delta came in, and all these settings we talked about, nightclubs, closed, congested settings, and we just saw this explosion of cases in the Netherlands. While on the other side, somewhere like Germany, they've been opening up. Whatever, obviously, I think it's probably fair to say they've had no less exposure to Delta than the Netherlands, in terms of travel or anything. It's just that obviously how the pandemic's been managed there, we've seen a very different path the last few weeks compared to the Netherlands, and obviously a lower rate going into this few week period. So worth pointing out there's different stories across Europe. I suppose I would take from this chart is that we have choices, and different choices have consequences. And so that's what I'd say. And the last thing I'd say is, just kind of putting on my economic analysis hat. Lockdowns are obviously extremely costly. On the other side, just letting the virus rip is extremely costly. So it's all about the measures we've talked about on these webinars of public health systems, public health information to try and go about our business as safely as possible. So hopefully that sets up the talk today, and thanks for everyone's time.
Thanks very much, James. Have you any comments on the modelling that's been taking place in Ireland about what might happen under different scenarios? Do you think there's been enough of that seen publicly?
Yes. So in terms of, so my impression is that, for those interested, those, the models, the assumptions, the data is quite transparent, but it is quite, you really want to go dig for it, and maybe it's I suppose it's hard for the layperson to understand what's going on, but the models being used are kind of a standard epidemiological models. So in that, I know there's some talk about people saying, "Oh, how peer reviewed are these models?" But they're standard in their kind of mathematical structure. They're open and transparent. People can see what's going on, and we've had these sort of experiments in the sense of we can look at the next island and see that, or look at Netherlands now. You can see that the model projections of explosion of cases under certain circumstances, given current vaccination levels, wasn't an abstract notion, but has happened. So models that predict that, in that sense, haven't been off the wall.
One of the criticisms of the models has been, of course, the assumptions that are made and the scenarios that are factored in. And James, unless you've seen models that I haven't seen, very few of those models factor in public health measures, broad public health measures, such as improving ventilation or increasing resourcing for find, test, trace, isolate and support, and all those sort of things. Why do you think those models or modelers are not taking into account those sort of factors when they're drawing up their models? Because it seems to be a very sort of static, unimaginative, non-action orientated modeling process, a sort of voyeuristic view of the future, if that's possible to say.
And I would. That's a great point, and I've been long in a different domain, but I've been long fascinated by the use of models in public policy and or private corporate strategy also. And there's probably lots of sociological reasons, but I'm going to spout my own theory here now. But I have a sense that that passive element that you're alluding to comes from maybe if you're looking at past pandemics. Well, we didn't have the information technology, we didn't have the same technologies we have now. It was maybe a more passive world, and there was less you could do, perhaps. And so I have this suspicion that there's an element of that going on, bringing that in from the past, and this passive approach flows from that. And the other thing I would say about this idea in the models that once you're infected, you drop out of the system, you're no longer vulnerable. And I think that has created problems. Just this is my total personal opinion, because we've seen them announced in Brazil, we've seen in India, the issues of reinfection when a new variant comes along. And I think it can make, in certain quarters, my impression, and this is an outsider looking in, but I get the impression that when there's almost a benefit from infection, comes out of it, because you do have immunity, great, and that's how pandemics probably did end in the past. But we can do better now, and we've seen this reinfection emerge in certain regions when a new variant comes along. So I think the short answer to your question is sociological of how of a modeling community and how things have worked in the past, and maybe some of the underlying conditions of our world have changed in the meantime.
Great, James. Thank you very much for that insight. We might come back to you when we're talking about some of the economics issues further on. Today's theme is enough fairy tale epidemiology. How should Ireland react to the Delta variant, to the rise of the Delta variant? And we're going to work our way through some of the things that appear to myself and my colleagues to be within the realm of fairy tales. I mean, Ireland is known as one of the subtitles is the land of myths and legends, and there are certainly plenty of myths being built up around COVID-19. And we'll do our best as we go along for the rest of this session to dispel some of those myths. Can I turn to Jerry Killeen? Would you like to kick off with your favourite myths and fairy tales of COVID-19?
Thanks, Gabriel. Well, that would be a long list, but I think I'd just like to build on something that James said. So with my regular bugs, that reinfection and the antigenic diversity is much more extreme than COVID. And basically, we can't model them with standard SIR models. And so now COVID isn't that extreme, but those are things we need to keep in mind. People have asked me what I think of the NEFIT modeling. And what I usually say is that these are reasonable and plausible scenarios based on the fact that these are models. They're not detailed ordnance survey maps of what our landscape ahead looks like. They're more like signposts on the road. They tell you roughly, what the consequences of your choices might be expected to look like. My biggest criticism is not the modeled scenarios, it's the one that they didn't model. And that's attached to one of the great fairy tales of COVID that Australia, New Zealand, Taiwan, and China have all proven wrong, and that is that it will inevitably become an endemic disease. We know from measles, which is more transmissible, that you can eliminate it. Ireland has eliminated it, and the scenario that's missing from the current NEFIT modelling projections is the aggressive suppression option, which gets us out of this sooner rather than later, and saves us several months of being stuck in a pandemic. So that's my big criticism, is that is another fairy tale that the modelling supports, through scenarios that are conspicuous by their absence from the simulations.
Great, Jerry. I think measles is a good example, if only because Ireland has happily eliminated measles, but Britain hasn't, and Britain lost its elimination status in 2016 because of the neglect of the public health system, really. And so vaccination, it just plays to what we know to be a truth, not a myth, that we need vaccination plus public health measures and a public health system. Would anyone else like to contribute their current favourite myth or legend? Tomas Ryan.
Excuse me, can you hear me now?
Yes, Tomas, you're fine.
Okay. Just to thank James for the excellent evidence-based introduction to where we are in the pandemic in Ireland. From my perspective, it seems one of the principal myths that we currently have is false comparisons with other countries. In the media present and in the public conversation, including in our politics, we're hearing a lot about the next couple of weeks, when we can open up things sooner, when can we have more indoor dining, when can we have more travel, and so on. And the comparison has been very much focused on where the restrictions are in other countries in Europe. And of course, on its own, it's a meaningless comparison unless you compare the epidemiological facts of those other countries. Comparing the restrictions alone is as meaningless as saying, well, there are rugby matches without face masks happening in New Zealand, and there are nightclubs opening in New Zealand right now. So why can't we do that too? And of course, it's because there's no COVID in the community in New Zealand at all. Right now, Ireland has amongst the worst COVID-19 daily case numbers in Europe. This has been the case for some time. We've been in the top 4 with Spain, Portugal, and the UK. Now, of course, the Netherlands has passed us out because of the recent explosion. So we're in a bad state, and we've been in a relatively bad state for some time. We never quite managed to properly flatten our third wave because we kept topping things up with international travel. So we never were able to keep our R numbers significantly below 1 for enough time to actually get below 300 to 400 cases a day. Since then, the R number has gone significantly above 1. We have exponentially rising case numbers. And regarding the NEFIT models, which I think everybody on ISAG agrees are completely competent and legitimate in how they were done, their optimistic scenario, which in my view was not optimistic enough, I think it's the view of ISAG in general, that NEFIT's optimistic scenario was not optimistic enough because it accepts 250 prospective deaths despite our high level of vaccination. And its pessimistic scenario was probably not pessimistic enough because it can get worse than that. But the reality is that all of NEFIT's models were based on the assumption that we would open indoor dining. Now, since then, we have not opened indoor dining, and yet currently we are actually on the trajectory towards NEFIT's middle scenario. And that is not a good path to be on. So we are realizing this now in Ireland. On top of that, as has been pointed out, we can see what's happening in the UK and in the Netherlands. And you hear a lot, of course, of legitimate questions about hospitalization. Is the link between hospitalization and case numbers broken? It has not been broken. It has been weakened. But if we get enough infections, we will see increased hospitalizations. And it's too early to see evidence of this in the Dutch case. But in the British case, it's become very clear because as of yesterday, we saw 500 hospitalizations in the United Kingdom. And it looks like the doubling time for UK hospitalizations is it's about 2 weeks. So we're seeing exponentially increasing hospitalizations in the UK. And this is even before a grand reopening. So the UK are heading towards a situation where by August sometime, they will be seeing 2,000 hospitalizations a day. Now, if you were to transfer that to Ireland and imagine a situation where we were having 200 hospitalizations a day, I don't think that's a situation that anybody wants to see happen here. And that's before we get onto the conversation about long COVID. So what worries me particularly about the Irish situation, in summary, is that we seem to have a fetish for lockdowns. Everything we're doing seems to be about engineering the maximum probability of us ending up in something that looks like a lockdown. Because what we're doing is we're waiting until the last minute, we're waiting until panic stations again, before we end up doing what needs to be done. And if we took a more prospective approach, if we took a more scientifically informed strategic approach of aggressive suppression to get case numbers down, we could have one of the best situations in Europe, not just because we're an island that has a lot of control over travel, but because we have the highest vaccine enthusiasm in Europe. And that's a fact that we have the ability to vaccinate the most people in Europe based on the fact that citizens are most willing to take them on. And so we can outperform Israel in that respect, and we can learn from Israel in using vaccinations with a vaccine plus strategy to keep cases low in the community as much as possible. But we're not doing that. We are being extremely passive at the moment. My concern is that we're going to find ourselves in a very uncomfortable situation in August that will turn into an ugly situation approaching September, where we'll have in parallel the issue of significantly increasing hospitalizations, some increase in death, though hopefully we'll be able to act early enough to prevent deaths from becoming too significant. But in my view, hundreds are not acceptable, and 1,000 is certainly not acceptable. And the issue of the Delta variant tearing through our schools in September, October, resulting in an awful lot of long COVID. And the situation we'll have gone through this very edgy, very uncomfortable summer that will end essentially with what feels like a lockdown going into the autumn, where it will be much more difficult to aggressively suppress this virus. Now, I put all those things on the table Not to be negative, I put them on the table because I think a large part of the mythology that we're currently falling victim to in Ireland is fog and keeping our head in the sand, not paying attention to what's happening around us, and really squandering our own advantages. And there are realistic ways of approaching this. I don't think any of us is expecting that we can set up a South Korean-style testing and tracing infrastructure by tomorrow. I don't think anyone thinks that we can triple our public health physicians by next month, although that would be wonderful. We could have the same number of public health physicians as Scotland then. But based on things that are in our arsenal, things that have been used already in this country successfully, we could have a much more sensible strategy that would result in the maximum level of freedom for everyone.
Okay, Jerry, did you want to come back in?
Yes, Gabriel, and I'm just going to share some views that I'd appreciate your thoughts on as well, because you're in the UK at present, and I see that yesterday folks in New Zealand accurately described the plans for the UK as like an optimized experiment to select for vaccine resistant new variants of concern, and that's my big fear. I am worried about the fourth wave, but I'm much more, concerned is the wrong word. I'm really worried about a fifth wave of something worse than Delta. Now, if I look at the myths and legends that the UK plan has been built upon, here's my short list. The first one is that an exit surge of hospitalizations and deaths is an inevitable part of exiting the pandemic. So that's just patently untrue. Summer deaths are somehow better than winter deaths. That it's better to get to herd immunity through natural infection fast than to get to it through vaccination a little bit slower. And the big one that really troubles me is that COVID is benign in children and young adults, and that schools are safe. Full stop. Simple as that. So those are I'd appreciate your views on it from a UK perspective, living there, and what are your thoughts about those fables?
Yes. Indeed, there are plenty of them around. Thomas mentioned one of them, that the link has been broken between cases and deaths and admissions and so on. Completely untrue. As Thomas said, the figures published yesterday showed that in the last 7 days, the hospital admission rate has gone up by 54%, and that's just in 7 days, and deaths have gone up by 50%. So there is no question that not as many cases are turning into hospitalization and deaths, but it's completely wrong to suggest that the link has in some way been broken or even severed. People are saying that's completely wrong. I think one of the other strange underlying myths in the UK is that, and I see it playing out a little bit in Ireland now with the notion that it's vaccine passports and it's all right for people who are vaccinated to do whatever they want. Vaccination isn't 100%. It was never 100% protective, and we know that the variants are nibbling away at that, and some to a greater extent than others. And I was very struck in the Independent Sage, the UK-based advocacy group equivalent of ISAG, and one of my very distinguished colleagues, Anthony Costello, told he has had an infection of COVID-19 within the last few weeks, and he got that, and he's been very much affected by it. And he had that despite being doubly vaccinated and having been vaccinated for some weeks. So there's no break between vaccination and infection. It is certainly reduced. And if you get that infection, your chances of being admitted to hospital are reduced, and your chances of dying really reduced quite substantially. But to pretend that the game's over because of vaccination is really, really wrong. Summer deaths and the surge principle, I was astounded to hear prominent people advocating this idea that it was better to go now in terms of removing everything and getting people affected and having the deaths an illness now rather than having it in the autumn when the health service will be under pressure because of more seasonal illness. As if the health service there isn't a health service, I'm sure, or a hospital in these islands that isn't trying its best to catch up with all the work they haven't been able to do because of the pandemic and because of the badly handled pandemic, that their work has been interrupted and people's health has been affected. And to somehow think that that's going to be better to have those illnesses and deaths now rather than later is wrong. And I very much agree with our own Mike Ryan this week, who, when he was asked a question about the UK strategy, first of all, he did express some surprise that it could possibly be the UK strategy. And then he described the notion of actively getting people infected, which is in essence what it involves, as moral emptiness and epidemiological stupidity. In his usual very pithy, short way, I think he captured the nonsense of that particular fairy tale that it's some sort of good thing to do. And I think also with the surge, the idea that you have to have a surge is absolutely not true. You just have to look at the way different countries have handled their use of vaccination and their backing up of that vaccination program with really good public health measures to make sure that there was a smooth landing. That sort of path down from the mountain leads to a level plain, not to a rocky field where many will trip over and become ill again. So these myths are very, very potent, and we need to be conquering them. And one of the important ones now, I think, is this issue of what can and should be opened and how it should be opened. I'm amazed that we're not seeing a huge program of work going on at the moment to improve ventilation. In the UK, at least. I'm not sure about the situation in the Republic of Ireland, but I'd be very surprised for the country that first protected workers from environmental tobacco smoke wasn't concerned to protect workers from COVID in the air in workplaces. But in the UK, it is a legal requirement to provide employees with fresh air. And the definition of fresh air has definitely been changed by COVID-19. And we do need programs of work both to improve ventilation and also to monitor that ventilation and to approve premises. So I think there are a whole string of these myths that abound that are really, really important that we kind of address. Would anyone else like to come in? Tomas?
Yes, thank you, Gabriel. I think it's important for us to point out that ISAG very much welcomes comments made recently on Taoiseach Micheál Martin, who rejected Boris Johnson's strategy in what I think could only be described as the strongest possible terms on account of the long COVID costs, if not the hospitalization costs and the deaths on top of that. I think it's also important to remember that the UK strategy of opening up in summer to reduce cases in winter is part of a much longer term perspective, which also acknowledges that there will be a wave of cases in and around spring 2022, and that this is being viewed in that kind of long-term framework, but is taking a strategy which I think everybody here very much takes issue with, which is that instead of throwing you to the wolves in winter, we will throw you to the wolves now in summer because hopefully it won't be as bad. And that if you take an aggressive suppression strategy, you don't need to take either approach. You don't need to have that choice. You don't need to make the choice to create immunity by infection and to accept the loss of life, to accept the loss of health. That is a choice that you don't need to make. But the UK is, it seems, the only country in Europe that is really looking around the corner right now. It's really looking around the corner, not just at the next month or two, it's looking around at the next year. And it's made that decision. And what we need to be doing in Ireland is making our decision for when we look around the corner. What is it that we see for the next 12 months in real terms? and how do we want to manage the weather that is going to be there, both domestically and internationally for us. What we know from Micheál Martin's statements is that the government is not willing to accept the losses of young people's health and the risks to our hospitalization system and a large loss of life, which Boris Johnson is willing to accept. If Boris Johnson is willing to accept 20 to 30,000 deaths over the next 6 months, the government of Ireland has essentially ruled out that strategy in very firm terms. So given that, we know that we don't have a vaccine plus herd immunity by infection strategy in Ireland. We have to make a choice between having a vaccine-only strategy or a vaccine plus public health strategy. And the vaccine-only strategy is really going to lead to the maximum restrictions that will be necessary to keep things from going in the way the United Kingdom is going. I don't particularly want to live under those conditions for the next 6 months. I think it will be very restrictive. I think it will be bad for the economy. And I think it will have very significant effects on things like education in Ireland, certainly on third level education, and probably to a significant extent on primary and secondary education. So we need to have a way of frankly looking at the next 12 months, which the British are doing, but to decide what does that look like for Ireland and what is the best thing that we can do, that we know we can do to reduce cases so as to open up the economy as much as possible. And in the short term, it seems to me to be very clear that allowing vaccinated people to travel from the United Kingdom without any kind of at-home quarantine or testing after arrival is a significant mistake that needs to be reversed as soon as possible.
Thank you very much, Thomas. I had a call from a journalist just before we went on air to say that they expect this afternoon the UK government to move the Balearic Islands from green to red, not even pausing in orange along the way in terms of, or amber along the way, in terms of restrictions, which is an amazing indictment of the strategy that somehow international travel was going to be all right anywhere this summer. Such a short-lived policy, and I do very much endorse Micheál Martin's description of the Downing Street policy as a let it rip policy. I think that's absolutely right, and he was quite right to condemn it. I'll come to Ivan Perry first, and then to Simone. Simone, I'd be very interested in your comments about this issue of the rights, what rights there are for workers in being placed in difficult situations now, when they're going to work, and can they expect any protection from anyone along the way? But can I come to Ivan first? Ivan.
Thank you, Gabriel. I suppose I just would, for me, there are sort of three core myths that are kind of, influencing our teaching without covering the ground that we've already covered. There's first of all the core myth that we can temporize with the virus, that we can reach some steady state where we can sort of live with the virus, and I think that's a very pervasive myth that has been hugely harmful. The second myth, and this comes up, and Tomas alluded to this, these absurd comparisons when we're looking across Europe, and the media need to be much more robust in challenging people who are saying, look, in Denmark, they're allowing people into restaurants on the basis of kind of antigen testing or whatever, without any regard to the multitude of factors that vary between Ireland and Denmark and so on. And then I suppose the sort of third myth, which in a way is quite perverse. I mean, we've been arguing for an aggressive elimination strategy with the target of zero from the outset, and of course with the successful development and introduction of vaccines. That target now is much more feasible, the sort of vaccine plus target. But instead we kind of get the argument that now that because everybody is going to be vaccinated, the whole zero COVID concept has become redundant, whereas in fact zero COVID, or this idea of aggressive suppression with a target of zero and elimination target is now potentially in sight.
Thank you, Ivan. Simone, would you like to come in on that rights issue that I raised and anything else you'd like to contribute?
Yes, I would. I was drawing your attention first just to some questions from the audience, so maybe we can deal with those and then move on to talk about the rights of people and unvaccinated people who are working in those sorts of settings. The first question is from Nessa Childers, and it relates to the conversation we've just had. And she's asking, is the intent in the UK to actually let the virus burn through the unvaccinated? And if so, what will be the outcome? Will the outcome be herd immunity? And if not, what will it be? And there's a second question from Stephen Foy about the use of ivermectin for treatment and prevention of COVID-19, and maybe someone could briefly answer that. Yeah,
I probably deal with both of those. The first one from Nessa, yes. Thank you very much for the question. Yeah, I think, as I said, Micheál Martin got it right. It's a let it rip policy. And I think at the back of it is definitely their idea of herd immunity being achieved by, originally they were thinking by natural means, by just not doing anything about the virus and taking it on the chin, as Boris Johnson said. But now it is herd immunity achieved by a mixture of vaccination and natural infection. Amazingly, they're not making any moves, even though the vaccine is approved in the UK for 12 to 17-year-olds, not making any move to vaccinate young people, and are relying indeed on natural infection as to get them to what they believe will be herd immunity. I don't believe herd immunity is achievable. It's very, very rare that an infectious disease can be dealt with purely by vaccination and kept under control purely by vaccination. Measles is a good example. It requires substantial backup in terms of public health action and investigation and dealing with outbreaks and suppressing outbreaks to keep vaccination under control. And that's how we got rid of smallpox. It wasn't all down to the vaccine. The vaccine was important, but it was the public health efforts that went in. So I think that's quite right. And there is no change on ivermectin. There is no evidence base for its effectiveness. I wish there were more drugs that were effective, but it's not one of them. Simone, can I come back to you?
Yeah, in relation to employment rights and health and safety, we think of indoor dining settings as places that we go to have dinner or go to have a drink, but they're of course places of work, which we understand from the incredible public health move to ban smoking in public places due to the large amounts of people who worked for years in pubs who developed lung cancer and other smoking-related cancers, which Micheál Martin brought in Ireland. We now have a situation, though, where, as I understand it, as a lawyer, I'm a litigator, so it takes a while for those cases to reach me. But I understand from talking to my colleagues who work at the corporate end of the work that there's little or no change in relation to health and safety advice and employment rights advice about having a safe place of work in relation to COVID. And I think there's also little understanding or questioning by the private sector. And again, this is anecdotal because this is something I asked my colleagues in relation to whether those employers are insured to cover whether if there's an outbreak in their place of work, and if that outbreak is traced to that place of work, or indeed a place that public liability would cover that people visit, whether they would then be insured to cover that. And I suppose I think of it as the social contract. We are all looked after by each other. Sometimes that's through the state, and sometimes that's through private insurance. And we're going to have to figure out the hard way, if we don't plan for this, how the costs of these outbreaks are going to be covered and how those people are going to be looked after. And I suppose this has maybe been particularly on my mind. I know we've talked about this before, Gabriel, but I personally experienced the only setback in my working life ever, and my high octane levels of energy were after I caught the H1N1 swine flu variant in 2009. So I was very sick for 2 weeks with the flu, with the swine flu. But after I got better and went back to work, I got sick again with a chest infection that turned into pneumonia. And I got better from that. And then I got sick again with an ear infection, an acute ear infection. And then I got better for 3 or 4 days and I got sick again. So for 6 months after having the flu, I had what I later understood as a post-viral collapse from having it. But for 6 months, I could barely work. And I run, big commercial court cases, and I need to be in court and I need to be with my clients. And for the first time in my job, I was all sick, and in a way that no one could do anything about. Now, luckily enough, I recovered completely, and other than the odd head cold, have not been sick since. But the cost of that was carried by the state ultimately, because I got a certain amount of sick pay from work, but then afterwards was covered by the state. And of course, colleagues of mine there's the other capacity cost, had to step in and help me with my files, and the cost of the people I couldn't look after in my life that I would normally have taken care of. So all of those rights are there to be discussed, and the cost of that, whether it is to private businesses, to insurance companies, or to the state, as well as the very human cost of serious illness like that. And of course, with long COVID, we're talking about a very high percentage of the people who are infected.
Thank you very much, Simone. Dan, did you want to come in?
Yeah, I had a question for Jerry, or perhaps for others, which relates to indoor dining and the encouragement for children to go, as long as their parents who are with them are fully vaccinated. Would somebody like to comment on that as another persistent thing offered to the public as a form of encouragement?
Yes, Jerry, would you like to comment on this idea that somehow it's fine if the parents are vaccinated, but the children aren't vaccinated, that there's some magical myth around that?
Yeah, I think, as Paul would say, that's really full-on Harry Potter magical thinking. There's no other way to describe that. There's no technical basis for it. I understand this is a political construct. We know that children get infected. We know that it is not an entirely benign disease in children. And in epidemiology, you're always you always get variability in your ease of detection of cases in different age groups and different sectors of society. And we know with kids, it's particularly difficult to pick up an infection by standard techniques. However, we know from serological studies, including studies here in Ireland by our own HSPC, that when you look at people's history of infection, that actually kids are infected just as often as adults. We don't see them as often because they don't usually get as ill, but they certainly do get infected. They do pass on infections. And the idea that a family bubble remains a bubble when it goes into an indoor environment with lots of other families, that bubble bursts at the door. Yeah, and it's over, it's gone. So that's absolutely a myth. I just want to come back to another myth that was raised very nicely about the difference between natural immunity and vaccine-induced immunity with respect to herd immunity. And I can see that Gabriel already has antibodies against the term herd immunity, because it's been so badly abused in a way that is technically inaccurate. So when I use the term herd immunity, I'm talking about herd immunity as a proper epidemiologist understands it, which is actually a very useful thing, right? So with measles, even when vaccines don't take us all the way to herd immunity thresholds, it's extremely useful that they get us close. And that's what makes measles a manageable disease with public health, because otherwise it wouldn't be. Now, to distinguish between natural immunity and vaccine-induced immunity, coronaviruses are so successful specifically because they induce a natural form of immunity that is inadequate. It's not strong enough to begin with. It fades very fast. And that's what you see in Brazil. When people talk about an endemic transmission pattern, go look at the trajectory that Brazil has gone through. That's an endemic transmission pattern. We're getting very close to it. And that's where Gamma emerged from. It emerged from a population that had enough natural immunity to select for a new variant of concern, but not enough natural immunity to stop the pandemic dead in its tracks. So natural immunity as a way to achieve herd immunity is totally valid. It has no technical basis, and that is nothing short of an urban legend. I think, let me stop there.
Anyone else like to come in on?
Just on the long COVID issue, Gabriel, I think it's, as a neuroscientist, I'm very, very concerned about the long-term effects of COVID-19. We don't know enough about this virus, but we do know it affects the brain, and it does have significant effects on brain function. But on the subject of long COVID, I think it's important to express some degree of solidarity with our British colleagues, not just at Independent Sage, but everybody working in the UK towards strategies that will deal with COVID-19 in an evidence-based manner. And I think that there are many people working at every level of the British infrastructure to do everything they can to reduce the effects of what the Boris Johnson government's policy on COVID is and has been. One of these is the NHS's, National Health Service's, recognition of long COVID, particularly long COVID in children. And we saw this summer how the National Health Service ring-fenced 100 million UK pounds to set up 15 different pediatric long COVID clinics throughout of England. And Scotland and Northern Ireland are doing similar things in their countries. And this is recognition of just how many children are experiencing long COVID already in the UK and how many will. At least 12,000 children under the ages of 12 have experienced long COVID lasting many months, according to the UK Office of National Statistics. And at least 20,000 British teenagers have also experienced long COVID, that is people aged 12 to 16 years of age. This is happening too in Ireland. However, we have not yet gotten around to putting in the investment to mitigate for the damage of long COVID. And the lack of harmonization, of course, between Northern Ireland and the Republic of Ireland with respect to healthcare was very evident when it came to the vaccination program. And people were patient enough with this on the grounds that we were moving more or less at a European speed in the Republic of Ireland. But when we come out of this, there is going to be a significant long COVID burden, not just for children, but also for teenagers and adults. And there's going to be an apparent difference with how Northern Ireland and Ireland, or how Ireland and Britain are dealing with this. So it is in our interests, not just as citizens, but it's also in the political interests of the people running the country at the moment to reduce the impact that long COVID is going to have on our healthcare system for years to come.
Thank you, Thomas. Yes, I very much agree with that. Before I go to Jerry, I just want to make a point I've made several times before, because I feel it so viscerally, I think, and that is that it is a really, really bad idea to infect young children with growing brains and developing brains with a dangerous virus, almost irrespective of how much or how little we know about it. And we know so little of COVID, as you correctly said. And I've never forgotten my learning when I was training as a public health physician, about the aftermath of the Spanish flu pandemic in the United States, where there was a real epidemic of Parkinson's disease in the years following that. Now, obviously, we're in a different scientific milieu, and it might be possible to answer that question. Will it cause something like this? Will COVID-19 potentially cause Parkinson's disease or some other disease in the future? We just don't know. And the precautionary principle should apply. We should be doing everything we can to help children and young people avoid being infected, not regarding them, as the UK is regarding them, as pawns in a really very flawed herd immunity strategy. Jerry, final words from you, Jerry.
Yeah, I think the great tragedy of what's happening in the UK is that the UK has, one of the world's best health services and an awful lot of the world's best epidemiologists in some of the world's best universities. A lot of them are colleagues and friends of mine. A lot of them have had to drop what they were doing to work on COVID. So we have that combination of expertise and competence and commitment with a government that just doesn't listen to them. And the end result is that you get the best epidemiologists dealing with the largest amount of data because the UK has so many cases. Now, if we don't learn from that, then, we're just extending that tragedy here to Ireland. And then one myth I really want to put a pin in, it's a total myth, is that our border is not manageable. Okay. If we're seriously talking about certification to enter a pub, then surely, we can do the same for our border and set up border bubbles for our border communities. But, the wild night on the rip in Belfast, all that's got to stop. And I know that's happening at present. I got my vaccination certificate by email yesterday. I understand there's 1 million of these going out, over the course of today. So if we can do that, then why can we not have a border bubble system where somebody who lives on the border just pops a printout onto their dashboard, police scan it as they go through, check the ID, just make sure it's somebody who does live in the community, all verified on the basis of a local address. It's not rocket science. It can be done. There have been, and I note also that when it comes to roll-on, roll-off rate, that at the peak of the Brexit crisis, containers were going from Britain to France without the cabs and without the drivers. So all these things are possible. Our biggest endemic disease at the moment is defeatism and excuses, and we've got to change that.
Thank you very much, Jerry. A good note for us to finish on today. Thank you very much for joining us with this briefing from ISAG. We will continue doing what we've been doing since the inception of the organisation, which is trying to bring independent scientific advice and public health expertise and other forms of expertise to bear on COVID-19, the biggest public health crisis this state has ever seen. Do follow us on Twitter and do join us again for a future webinar if you possibly can. It's great to have you in the audience. Thank you very much. And thank you to all our speakers, and particularly to James for his excellent data presentation at the very beginning. Goodbye and have a good day.